So I think echo हो रहा है मेरा.
Sir, you can mute.
या
मैं वही कोशिश कर रहा हूँ. इसी करते हैं.
आपका 2 डिवाइस से लॉगिन होगा तो तभी ऐसे.
हाँ, मैं 2 डिवाइस से मैं भी म्यूट कर रहा हूँ. Okay. So everyone is ready.
यस.
अभी भी तो ये अभी म्यूट कैसे? मैं तो म्यूट कर. Good evening, everyone. It's still my mistake. अब ठीक है?
हाँ, ये ठीक है.
Good evening, everyone. Today we are starting our another edition of Hand to Shoulder Academics program. Today we'll be talking about imaging of normal shoulder, which would be presented by Dr. Amit Sahu. He has done his fellowship in MSK Radiology from University College of San Diego and University College of Michigan. He has been mentor of MSK Fellowship Program, and he has multiple publications and book chapters, and he has been faculty in various conferences and workshops. So let's not waste time. Dr. Amit, you can start your presentation.
Thank you, sir. Thank you for inviting for this lecture. So today we will be discussing on the normal anatomy of a shoulder imaging, where we will be also talking of what all things to be seen in which all imaging modality, and when do we advise which modality. Like many times the patient comes to the orthopedicians and they examine, and then they still think that there are we have a lot of imaging options, so which imaging should be advised. So not to give any less importance to the radiograph when we start with in orthopedics, whether we talk of a trauma, whether we talk of arthritis or tumor, the first and foremost and non-dispensable imaging is the radiograph. So definitely we start with the radiograph, and then as we move on, we have other imaging modalities in our bucket. Like we can do fluoroscopy, we have CT scan imaging, we have MRI. As we are doing frequently the kinematics and dynamic imaging, both in ultrasound as well as fluoroscopy and in MRI. To differentiate between the kinematic and dynamic. So kinematic is when we do a fixed position imaging, but the position varies from in sequence to sequence. So if we are talking of wrist, so either we can do dorsiflexion, we can do palmar flexion, but in a fixed position. That is called as kinematics. Whereas in dynamic, there will be a continuous movement of the concerned joint by the patient, and then we do the scanning. Coming to the radiograph, so there are at least 14 named radiographic views in a shoulder, but there are 3 basic views which we do. The rest of the views, they were done in past because the options of further imaging like cross-sectional was not there, like CT and MR was there in very few places. That's why there were so many different positioning radiographs were there to see different parts of the shoulder. So basically when we are talking of a shoulder joint, so there are 3 main bones which form the shoulder joint. The humerus, as we see this, shoulder, the scapula, and the clavicle. So these 3 bones form 2 joints which we call as a whole the shoulder joint. So one is the glenohumeral joint, which is formed by the head of the humerus and the glenoid. Other is the acromioclavicular joint, which is formed by the acromion process of the scapula and the lateral margin of the clavicle. So this, as you see, is a which you commonly see in a radiograph is the AP view of the shoulder, and this is what is called as the lateral view of the shoulder. So coming to the anatomy of a radiograph, so this whole thing which you are seeing a circle, which this is a head of the humerus. The head of the humerus, along with that, when we see two curves which are non-overlapping in the AP view, so the outer curve which you see is the greater tuberosity, whereas the inner curve which you see, that is the lesser tuberosity. In between is the bicipital groove where the passes the long head of the bicep tendon. It has an articular surface which forms the articulation with the glenoid. The glenoid is more or less a oval shaped structure, which the inferior 1/3 is actually a imaginary circle, whereas the upper one is a more of a fusiform structure. Then we have the coracoid process, which is anteriorly in the scapula. We have the acromion process, which forms the acromioclavicular joint with the clavicle. And then we have the body of the scapula, which is not a part of the shoulder joint. So when we are talking of a shoulder joint, we have to see the alignment of the glenohumeral as well as the acromioclavicular joint. Along with the alignment, we have to see whether the joint space is appropriate or not. There is no criteria or measurement as to say this is what the measurement should be. But by eyeballing, like when we see more and more radiographs, we know that this is definitely a normal looking AP radiograph. So when we are talking of pathologies, so before we move on to any specific pathology of a shoulder joint, we should first see an overall view of the radiograph, where we first have to see what is the density of the bone. So here, if you can see, there is the bones appearing as normal, hyper or brighter areas, which is all homogeneous in all the bones, even including the ribs. So this is a normal density of the bones which we are seeing. Then when we are looking at the joint glenohumeral and the acromioclavicular joint space, which looks fine, we should also look for the acromiohumeral distance. Here, if you can see, there is a good space which is seen between the acromion and the head of the humerus. Why it is important? So this gives an indirect evidence of the rotator cuff status. So if there is reduction in the humeral, the acromiohumeral space, and along with that, if you see, there will be some irregularity in the cortical margin, you will see some irregular areas of sclerosis and subcortical cysts or lucencies. So these are the signs of rotator cuff degeneration. Like there is a complete rotator cuff tear that has moved the humeral head above and it is impinging on the acromion. So that is a indirect and very good evidence of rotator cuff degeneration. Another thing which many times we do see, where even if the radiograph is looking normal with a normal space of the joint and acromiohumeral space is also normal, but you can see there is some sclerosis and cortical irregularity of the greater tuberosity. That is also a sign of chronic rotator cuff degeneration. What happens? The rotator cuff gets attached to the greater tuberosity, predominantly the supraspinatus, and there is a wear and tear on this surface, which causes that irregularity of the cortex as well as sclerosis and cystic changes, which is more evident on CT scans and the MRI. Coming to the lateral view, so this view is important to see whether there is any glenohumeral joint dislocation, whether anterior or posterior. This is the anterior part and this is the posterior part. So other thing which you can see, this is also called as the Y view, where you can see the spine of the scapula as well as the coracoid and the acromial process of the scapula. Here we can also see if there is any fracture of the scapular body. Along with that, we can also see the acromioclavicular joint in two orthogonal planes. The another commonly advised view is what is called as the axial view. Many times there is a confusion between the axial view and the lateral view. Many people talk the axial view as a lateral view, but in true sense, the lateral view is what is called as the Y view, whereas the axial views are these two views which I am showing you. So this image on the left side, is what is called as the supero-inferior axial view. That means when we talk of any radiograph by the specific name or the position, the first name which comes is the place from where the X-ray beam is being projected. So if it is a supero-inferior axial view, then the beam of the X-ray is from superior, whereas the cassette is lying inferiorly. Similarly, in case of the infero-superior axial view, the projection of the X-ray will be from the inferior aspect and the cassette will be lying in the superior aspect. Similarly, when we are talking of AP view, this is antero-posterior view. That means the X-ray is projected from the anterior aspect and the cassette is on the posterior side. When we are talking of a right lateral, that means the X-ray should come from the right side and the cassette should lie on the left side of the body. So what is the difference between the supero-inferior axial and the infero-superior axial, and when do we need these views? So this axial views is the another orthogonal view where we can see the glenohumeral joint, and through the humeral head we can see the acromioclavicular joint. So now, as the rule says, anytime we advise the X-ray, there should be orthogonal to at least two view X-ray should be advised. Why? Sometimes what happens, like in a single view, there will be overlapping of the pathology which is not seen in a single view, which becomes more clearer on the orthogonal or the 90-degree orthogonal means the 90-degree opposite plane view, where we can see that same structure in a different view and we can interpret if there is any pathology which is overlapping in a single view. So similarly, in the superior inferior axial view, what we are seeing the lesser tuberosity, we are seeing the greater tuberosity. In between, we are seeing this bicipital groove. We can see the humeral head very nicely. This is the neck of the humerus. We can also see that the glenoid is well exposed now to be visualized. And you can see the anterior aspect and the posterior aspect of the glenoid. This view can also be used to assess if there is any bony Bancards, where you can see there is a there will be defect in the antero-inferior aspect of the glenoid. In case of the infero-superior axial view, here you can see that the acromioclavicular joint is not overlapping on the humeral head, as which was seen in this view. So in this case, what happens, the humeral head is more well exposed without any overlapping structure, and we can see any subtle pathological changes in the humeral head, be it a small unicortical fracture or if there is a sclerotic or a lytic lesion. Also in this view, what happens, the overlapping of the glenoid by the humeral head, which was seen here, is not seen. So this glenoid is much more well exposed to assessment rather than in the supero-inferior axial view. So when we talk of this shoulder radiograph, still we do follow that there should be two orthogonal plane views, and among these three, we generally choose two. Definitely AP view is, we cannot say no to the AP view, it should be there. But among the lateral and the axial views, we have to decide based on what we want to see, which view should be advised. So this is what the normal anatomy, radiographic anatomy of a shoulder radiograph is. So coming to the ultrasound, which is a very good modality if a trained person is doing it. The only limitation is it is little observer dependent, and though people say that it needs a lot of training, but to be very frank and true, so the musculoskeletal ultrasound is not a very difficult thing. The basic thing which we want to know is the anatomy. So the anatomy of the structures and what the basic normal appearance of the structures should be. Like how should a tendon be looking? How should a ligament be looking like? How should a normal fluid should be looking? And how a synovitis will be looking? And then in ultrasound, we also have the advantage of dynamic ultrasound, where we can see a structure movement based on the type of movement which we are doing on a specific joint. The other advantage of ultrasound is we do have a color Doppler, and along with that we have a power Doppler. So what happens, this different types of Doppler signals, they show which part of the soft tissue or the joint is inflamed, and on follow-up imaging we can definitely see that whether there is improvement in the Doppler is happening or not. That indicates that whether the inflammation or the infection part which was seen in the previous imaging, that has reduced, and that is responding to the treatment. That helps a lot to the clinician to decide for further management. So among the musculoskeletal ultrasounds, the most commonly advised ultrasound is a shoulder ultrasound, which is the other point why we do a shoulder ultrasound more commonly than any other joint, is because most of the structures around the shoulder, they are quite well visualized in a ultrasound, and they are quite superficial. So when we are talking of the soft tissue structures around the shoulder joint, so the most common indication is for the rotator cuff, which constitutes by the 4 tendons, as we know: supraspinatus, infraspinatus, subscapularis, and the teres minor. We cannot just do in a single position all the structures we cannot visualize. So that's why there are specific positions to see specific structures. So I will be showing you in what position the left side of the image are this positioning of the probe and the position of the patient, whereas the right side images will be showing you in this position what all structures we can see. So this is a neutral 90-degree flexed position of the elbow, where we can see the long head of the biceps tendon. Here the probe is put horizontally, and you can see the biceps tendon, which is seen within the bicipital groove. So this is the greater tuberosity and the lesser tuberosity. Within it, you can see the biceps tendon. And when we put the probe horizontally, you get this view, that is end-on view of the long head of the biceps tendon. Just you have to move the probe 90-degree to the horizontal position, which becomes a long axis of the long axis view of the biceps tendon, which is seen in the bicipital groove. So this is the short axis view, and this is the long axis view of the biceps tendon, which when we are keeping the probe in the horizontal direction, we get a short axis. When we are keeping it in a vertical direction, we get a long axis. So in ultrasound, we always talk of a short axis and long axis rather than coronal, axial, or sagittal view as we talk in CT and MRI. This is because the axis of the structure which we are seeing, if we are seeing it in the whole of the length of that structure, we call it a long axis view. If we are seeing it in a end-on position, we call it as a short axis view. So always while doing ultrasound, we need to see in both the planes, short axis as well as the long axis view. So here, this is what is now we are seeing is a subscapularis. So in the same position where we were seeing the biceps tendon, we have to move the probe little medially, and we can see the long axis view of the subscapularis. Now here, if you compare it with the biceps tendon, in the horizontal position of the probe, we were seeing the biceps tendon in a end-on position in the short axis view. Whereas here, when we are seeing the subscapularis, because the subscapularis tendon is oriented horizontally over the glenohumeral joint, and where the probe, when we are keeping the probe above it, we will see the long axis view. And when we are moving the probe in a vertical direction, we are seeing a short axis view of the subscapularis. As you can see, this is subscapularis, as we know, it is a quadripinnate muscle tendon. So we are seeing all 4 pinna of this muscle. So 1, 2, 3, and 4. So in the soft axis, we can see all 4 pinna, whereas in case of the long axis, we can see the whole length of the tendon in one view. Then moving on to a most important tendon of the rotator cuff is the supraspinatus tendon. So in case of supraspinatus, in order to expose the supraspinatus tendon out of the acromion, we need to do a maneuver on the position of the patient, which is called as, so this is what is called as the modified Kras view. Not to remember the name, but to see the position, you have to move the hand backwards, so that the palm should lie on the hip as if you are keeping the palm inside your back pocket, and the 90-degree position of the elbow should be still maintained, and the elbow should be kept closer to the body. In this position, what happens? The supraspinatus tendon gets exposed outside, as you are seeing here, and we can see the whole length of the supraspinatus tendon. This is the long axis view. As you again move the probe perpendicular to what we were seeing in the long axis view, we see the short axis view of the supraspinatus. So this is what is the articular surface of the supraspinatus tendon, and this is the bursal surface. So here when we are assessing the supraspinatus tendon in the long axis view, we can see whether there is any articular surface tear, bursal surface tear, whether there is a full thickness tear. If you can see a thin rim of black line which is seen over the supraspinatus tendon, this is the subacromial space, and this is the minimal subacromial bursitis or fluid which is seen here. This is the space, again the subacromial space, where the fluid is not well appreciated as in the long axis view, but here we can see the short axis view of the whole of the supraspinatus tendon. Then we move on to the infraspinatus tendon. In this position, in this case, again the hand should be moved forward as we kept it for the biceps and subscapularis positioning, and the examiner should move back so that it is comfortable for him as well as the patient to see the infraspinatus and the teres minor tendons. So both these tendons can be seen in this simple positioning of the probe in the horizontal plane posteriorly by just moving above and below. So above is the infraspinatus, which you can see here, and below we see is the teres minor, this one. So teres minor can be seen just at the attachment of the tuberosity where there is a dip. So you can see both these tendons in the long axis and then in the short axis view by moving the probe. Another thing which we can see in the same position, which has ultrasound as an advantage, is the posterior aspect of the glenohumeral joint. So if you see, this is the glenoid and this is the head of the humerus. This is the posterior joint space. We can see if there is any joint fluid, and also sometimes what happens if there is a labral tear, posterior labral tear, and along with that we get a large cyst over here. We can say that there is a large paralabral cyst with suggestion of a posterior labral tear. So posteriorly, we can see three different things: the infraspinatus, teres minor, and the posterior joint space. So by this, we do complete the ultrasound examination of the shoulder. The last thing which I do see is the acromioclavicular joint, which is very easy to see by just putting the probe on the acromioclavicular joint surface marking, where you can see this is the clavicle and this is the acromion and this is the joint. So in the same position, we can move the probe little lateral, and here what is the view which comes? This is the acromion, and this is the supraspinatus tendon. This is the head of the humerus. This is the greater tuberosity. So why this position is important is, so in this position, by moving the, asking the patient to move the arm above and below, we can see if there is any subacromial impingement or not. So if there is a smooth movement of the supraspinatus tendon below the acromion, then there is no signs of any impingement. But in case of impingement, what happens? If you're seeing this whole supraspinatus tendon in a smooth pattern, there will be clumping of fibers over here under the acromion. So that is a sign of the subacromial impingement. So in this talk today, I am just focusing on the normal anatomy and normal structures, how we do see. As we move on with other pathological, radiological pathologies of the shoulder, I will be showing you all these pathologies. So this is one important view in the ultrasound also, where we see the long head of the biceps tendon end on, which is looking like absolutely white thing. And many times people call it as a calcification because this is looking like a cortex of the humerus. And I have seen many reports which do call this as calcific tendinitis of the rotator cuff. So this is a view where the biceps is seen here, supraspinatus is seen just anterior to it, and the subscapularis is seen here. Two ligaments can also be seen in this view. One is the superior glenohumeral ligament, which I will show you in the MRI, and also the coracohumeral ligament, which is seen above the bicep tendon. So these two ligaments can also be assessed. Also, this is in the rotator interval. If we are seeing any fat haziness, which is not seen here, in case of fat haziness, the dark area, this what we are seeing here will be seen over this area. And this is also a sign of adhesive capsulitis. So basically, in the ultrasound, we have seen all the tendons. We have seen the acromioclavicular joint. We have seen whether there is any glenohumeral joint effusion predominantly in the posterior aspect. We can see bursitis as well as the rotator interval. And we can talk of rotator cuff pathologies as well as biceps pathology. We can talk of adhesive capsulitis and bursitis and degeneration of the acromioclavicular joint. Coming to the more advanced imaging, which is the MRI, and nowadays MRI have come up in a big way because there are so many modified sequences where not only the structures which we talk of, like the gross structures, but we are also able to see much finer structures through MRI by different modified sequences as there is advancement in the machines as well. So before I move on to the normal anatomy of the MRI, I would like to talk of the positioning, what should be done when MRI scan of a shoulder is performed. Because based on this positioning, many times what happens, like even we do overcall some pathologies, even if it is not there. So the A image, which is been seen on the left side, here if you can see, there is like external rotation at the glenohumeral joint as the palm is raised up. So this is an actual correct position of examining a shoulder in a MRI. What we are seeing here, this is a dedicated shoulder coil. We can use also something called as body coil, like there will be a flat coil which is over the body over here. But the resolution in a dedicated shoulder coil is much better than a body coil. But sometimes what happens, if the patient is little heavy built, there is difficulty in positioning within this shoulder coil, we do use the body coil, though there is some compromise in the quality of the imaging. The image which is shown in B, this should not be done at all. What happens, there is an internal rotation of the shoulder, and there, in this case, the labrum, the glenohumeral ligaments, the assessment becomes difficult because the positioning changes. So we should keep in mind that whenever we are doing an MRI, this is definitely a technician's role, but we as a radiologist should definitely advise them to keep a proper positioning of the shoulder before we start the scanning. So I would now before we start on the MRI, so if anyone has any question based on this anatomy of the radiographic and ultrasound anatomy, we can discuss before we move on to the MRI.
Amit?
Yes.
What about? Okay, Jyoti, you can ask.
Yeah, Jyoti, please.
No, sir. No doubt, sir.
Okay, fine. Yeah,
Amit,
Vikas,
just give me an ultrasound.
as you say, your voice is getting echoed.
Please, sir, continue MRI. I have no doubt.
Yeah, no, Vikas sir is asking something.
I was asking ultrasound shoulder. Is it possible to assess labrum and slap?
So there are literature which says so, but actually the posterior labrum can be accessed, but slap is not possible. But the literature, there are articles which say that they are able to assess all the complete labrum, but the confidence level is very low.
And what about, is there anything like a contrast for the ultrasound? something
Yeah,
like.
there is ultrasound contrast, but they are more in musculoskeletal. They are being more used in for soft tissue tumors and in arthritis, and not for any internal derangement of the joint.
Okay, okay.
Can we move on to the MRI?
Yeah, we can move.
Everyone is able to see the screen?
Yes, we can see a screen.
Okay. So in MRI, there are, as I told, there are various sequences to assess different joints and different structures. In musculoskeletal imaging, there are four sequences which are very commonly used. One is what we are seeing in front of the screen is the what is called as the proton density fat suppress image. I won't go into the physics, but I will tell you some signs how to identify a specific sequence and what all to see in that sequence, what all structures to see and how pathologies can be seen. So here what we are seeing is a proton density fat suppressed. Why this is fat suppressed? Because generally what happens, this is the subcutaneous fat which we are seeing, which is all homogeneous, and it is looking dark. So the signal is suppressed. That means it is not looking bright. So the fat,
Excuse me, Amit.
Amit,
The
Amit, your
Yeah.
screen and our screen, they are not matching. We are seeing a Excel sheet, the document. Yeah,
okay.
you have to.
Now is it
Yes, now we can see. Yeah. We can see.
okay? So I was talking about this sequence. This is called as the proton density fat suppressed. I am not going into the proton density, but I am talking of fat suppressed sequence. So in fat suppressed, what happens in these sequences, the fat, whichever expected area of fat, they will look dark. So the expected area of fat in this image is the subcutaneous fat and the bones. So the bone marrow is also looking black and the subcutaneous fat is also looking black. So in the sequences where you will see the fat as black and also the marrow as the black, so these are the basically fat suppressed sequences. So there are various type of fat suppressed sequences. One of them is the proton density fat suppressed, which is routinely used in musculoskeletal imaging. Previously this was, instead of proton density, there were, when the proton density imaging was not there, people used to be using the stir image. Today also in many places where the people are not aware, the technicians are also not aware, they still do a stir sequence, but by rule the stir sequence should not be done when we are talking of musculoskeletal internal derangement of the joints. Yeah, when we are talking of say tumors and soft tissue or bony tumors, their stir has a role, but not in internal derangement at all. Okay, so when we do MR again, as we do in radiograph and ultrasound, we image in different planes. Similarly, in CT and MRI also, we have to see the structures in different planes. So what are the three planes which are available with us? One is the coronal, which you are seeing in front of you. Then we do have sagittal and axial images. So this is, if we see, this is exactly looking like a radiograph of AP view, which I showed the first image, where you are able to see the glenohumeral joint. As we move the cursor, we are also able to see the acromioclavicular joint. So the two joints are well visualized. We can talk of the joint space is normal here. Even the acromioclavicular joint looks fine. I was talking of the acromohumeral space. Here you can see that in that space lies the supraspinatus tendon that prevents the superior or proximal migration of the humeral head. That's why we are able to see the space in the radiograph. So here you're able to see this is what is called as the supraspinatus tendon. So the tendon in this sequence, like the fat suppressed proton density, it will look black or darker. Here, if you can see, this area is looking different from this. That is, this area is looking brighter. But again, here there is a curve in the tendon. So what happens when there is a curve in any of the structures? So the signal has a abnormality in this region, what we call as the magic angle effect. That is because the magnetic field is traversing through the structure perpendicularly, but here it is getting a curve. That's why in this area we do get an abnormal signal. We should always see this signal in other sequences to rule out completely that whether there is a pathology or not. But many a times, if you have seen that people do report it as tendinosis or tear, but actually it is not. It is a magic angle phenomenon, which is a normal looking tendon. So the tendon should look dark. The bones are looking darker here. The fluid will be looking bright. If there is any joint effusion, it will be seen brighter over here, either in any of the joint. As you are able to see that there is some bright signal which is seen in this region. What is it? It is the subacromial space. So there is some subacromial bursitis which is seen here. So in the coronal, we have to see from end to end the supraspinatus tendon. The whole tendon you have to see if there is any small area of abnormality or not. If you can appreciate here, this area is looking much more brighter or looking like a fluid as seen in this sequence, this area. So there is a small articular surface. This is the articular surface and this is the bursal surface. So there is a small articular surface tear of the supraspinatus tendon. So we have to scroll from anterior to posterior to see whole of the supraspinatus tendon. That is what we can see nicely in the coronal view. Also, we can see the whole of the glenohumeral joint in the same view from anterior to posterior. Other important structure which you are seeing here, this black thing, as I told, all the tendons will be looking black. This is the long head of the biceps tendon. This is the intra-articular part, which goes and attaches to the glenoid labrum. So here, this place is called as the biceps labral complex. So this area, if there is any abnormality, will be abnormal signal. The abnormal areas I will be showing in other talks. Then we are able to see the clavicle to the extent which we can. We are able to see the coracoid process where the sorted of the biceps is attaching. Then we are able to see the acromion and the attachment of the deltoid. So four structures which I told we can see very nicely in the coronal view. One is supraspinatus tendon. We can see both the joints. We can see the deltoid. We can see the biceps and the biceps labral complex. I am not talking of the labrum in the coronal view right now because I want to show you in the other view where you can appreciate much better, and then I will come back to the coronal view. Now, coming to the other sequence or other plane, what is the axial? This is the axial. Again, if you can see, this structures are looking similar to what was seen in the coronal image. So this is again the same sequence which I was talking of, proton density fat suppress image. So this is the axial proton density fat suppress. So here again we can see the glenohumeral joint very nicely. And when I was talking about the positioning in the MRI, so we can, even if we don't see the person how he is positioned, by seeing the image we can say that whether the positioning was proper or not. So here if you can see, the bicipital groove is lying anterolaterally projecting in, because here the palm was raised up and there is some external rotation at the glenohumeral joint. That's why we are able to see the bicipital groove anterolaterally. If it would have been a internal rotation, the bicipital groove would have been lying here. In that case, I will talk of the subscapularis tendon. This is the subscapularis tendon. It would have been shortened, and the pathology lying in the subscapularis would also have been difficult to see. So as we come, this is the superior most part or uppermost part of the axial view. And as I move down, I am able to see the clavicle. Then I am able to see the acromioclavicular joint. This is the acromion. As I move just below the acromion, I am able to see another dark structure which I talked of, the tendon. This is the supraspinatus tendon, which has a central tendon and it has muscles on both sides. This is a central tendon with muscles on both sides, where this is how we can differentiate between different types of muscles and tendons. Then as I'm moving little more down, the new structure is being seen here, which is again looking like to be a tendon. This is the intra-articular part of the biceps tendon, which I showed you in the coronal view. And as I move on, this again is the biceps labral complex. Then as I move one slice more, I am coming more closer to the glenohumeral joint. Anteriorly, I am able to see the subscapularis tendon. Posteriorly, this is the spine of the scapula, and I am just below the spine of the scapula is seen as the infraspinatus tendon, which is going and attaching to the tuberosity. So in this view, we are able to see the glenohumeral joint, the subscapularis tendon, and the infraspinatus tendon. Also, we can see there is the coracoid process, and if the distance between the coracoid and the humerus is reduced, which generally they talk of like 3 to 4 mm, here it is definitely more than 5-6 mm. So when this space or this distance is reduced, we talk of the subacromial impingement of the subscapularis. We can see the attachment of the subscapularis to the lesser tuberosity, the whole length. We can see there is a normal homogeneous dark signal that implies it is a normal tendon. As I am moving down, I am able to see the biceps tendon here within the bicipital groove. And also, as at the level where the subscapularis tendon ends, we are able to see a new tendon posteriorly, that is the teres minor tendon. So teres minor tendon is an eccentric tendon with the tendon lying eccentrically and the muscle lying towards one end. So this is how we differentiate it from the supraspinatus and infraspinatus tendons. I didn't talk of the labrum in the coronal view, because if you see the axial view, you can see very nicely there is the triangle structure which is seen anteriorly and posteriorly. This is the anterior part of the shoulder and this is the posterior part. You can see very nicely two triangles. So this is what is called as the glenoid labrum. So glenoid labrum is basically a rim of the glenoid, which we can see throughout the outer margin of the glenoid. This is the glenoid. So as we move up and down, we can see this is the uppermost part. So this is the superior glenoid. This is the anterior part. This is the posterior part. This is the anterior superior glenoid and the posterior superior glenoid. We can also talk of the clockwise position. Then as we move down, we can see there is the antero-inferior part of the glenoid. And this is the posterior-inferior part of the glenoid. And this is the inferior glenoid labrum. So we can see the whole of the glenoid labrum if we move from superior to inferior in this axial view. Sometimes what happens there, we do have some confusion about the labrum in this axial view. Then we do come to the coronal view to see if we are able to see it in a different plane. So here, if you can see, again, this is the superior labrum and this is the inferior labrum. This is the anterior part which I am moving. So this must be the anterior labrum and this must be the posterior labrum. But if you can differentiate very well that how it is little difficult to see in the coronal view, but it was quite easier to see in this axial view. So we'd always rely on the axial view for the glenoid labrum rather than the coronal or the sagittal view. Now, everyone can see there is, so we are able to see a continuous triangle, dark triangle posteriorly, but there is some interruption in this dark triangle anteriorly. So what it can be? So whenever there is interruption in the labrum, we should first think whether this is a normal anatomy variation or is a pathology. So as you see, this is the antero-superior part of the glenoid labrum, and we are seeing just a focal tunnel over here. So this is a labral infralabral fissure, what we call. So this is not a tear, and this is a fissuring. But if we see the antero-inferior labrum over here and compare it with the posterior-inferior labrum, here we are able to see the triangle as a whole, but here you are seeing that there are multiple interruptions in the labrum. So this is a labral tear. the antero-inferior labral tear. I think everyone can well appreciate between the normal labrum and this area of abnormal labrum, right? So in the coronal and axial, we have all assessed all the 4 tendons. We have assessed the biceps tendon. We have seen the glenohumeral joint, acromioclavicular joint. We have seen the subcoracoid and the subacromial spaces. We can also see the deltoid as a whole. We can see whether the bulk is normal or not, the signal is normal or not. Along with that, we also see the joint effusion and synovitis. Now, one more plane of examination is left, that is the sagittal. So sagittal is, we move from lateral to medial. So this, if we can see, this is the lateral most part of the shoulder where we are able to see the deltoid. As we move medially, we start seeing the humerus head, and we are able to see the greater and the lesser tuberosity. So, and we can see, this is what the view, I think in arthroscopically also you see the arc which is formed by the rotator cuff. So the supraspinatus, which is definitely above, which lies supraspinatus, anteriorly is the subscapularis, posteriorly lies the infraspinatus and the teres minor. So this forms a complete rim over the humeral head. As we move little more medially, now very well we can see there are different tendons which are seen intermingled with the muscles. So here, the superior most part is the supraspinatus. As we move from lateral to medial, as we are moving medially, we are able to see the whole of the bulk of the muscle of the supraspinatus, what is called as the Y view in the radiograph. We can see that the muscle is occupying the whole of this Y area, and there is also a bulge which is convex superiorly, which implies that the muscle bulk is absolutely normal. So again, moving from medial to lateral, we can see that this is the supraspinatus, and this is getting attached, inserted to the superior aspect of the greater tuberosity. Now, just anterior to the supraspinatus lies the long head of the biceps tendon, which we have already seen in the axial and the coronal views. Again, we can also see in the sagittal view. This is the place where it should go and attach to the labrum. So it forms the biceps labral complex. So this is the long head of the biceps tendon, and this is the bicipital groove between the greater and the lesser tuberosity. This goes the long head of the biceps tendon. Anteriormost is the subscapularis. Posteriorly is the infraspinatus, and posterior-inferiorly, what we see at inferior to the infraspinatus is the teres minor. So we have seen in this sagittal view, along with the tendon, we have to also assess the bulk of the muscles of the forming the rotator cuff. That is very important whenever we see chronic tendinosis or tear, because also the management for the surgical conservative, what type of surgical management, that also depends how good is the muscle bulk. Then another important thing which we see is just inferior to this is the coracoid process, and just inferior to the coracoid process is the subcoracoid fat triangle, which we call, though it is not exactly a triangle, but it is a space of the fat which we see below the coracoid. Now, if you can differentiate this sequence from the sequence which I showed you previously too, where you are able to see that the fat was dark, but here the fat is all bright, even the subcutaneous fat as well as the bone. So this is a non-fat suppressed sequence. So this is basically a T1 sequence. So in this T1 sequence, we see the fat very nice. So whenever there is darkness in this fat area in the subcoracoid in this sequence, the suggestion of adhesive capsulitis arises, and we say that there is effacement of the fat in the subcoracoid fat triangle, which indicates the adhesive capsulitis. The other important structures which we do see in the sagittal plane is there are few ligaments which we are very nicely seen. One is this is the coracoid and this is the humerus. So this is the coracohumeral ligament. Other thing which we see is this is the coracoid and this is the acromion. We can see the coracoacromial ligament very nicely. So just by moving from medial to lateral, we are able to see two important structures nicely, the coracohumeral and the coracoacromial. We can also see the superior glenohumeral ligament. So this is what is the superior glenohumeral ligament. I think I can try to show you in the axial view. So I have moved this uppermost section where the first thing which is seen just anterior to the labrum is the superior glenohumeral ligament. As we move down, we will see middle glenohumeral. In this case, the middle glenohumeral ligament is not there, which we see in 28 to 30% of the population. Then as we move more inferiorly, we are able to see a structure anterior to the labrum, which is the inferior glenohumeral ligament. This is the anterior band of the inferior glenohumeral ligament. And this small dot-like structure which is seen, that is the posterior band of the inferior glenohumeral ligament. Again, I will be coming back to the sagittal view to show you the inferior glenohumeral ligament anterior band, and this is the posterior band of the inferior glenohumeral ligament. So in case of adhesive capsulitis, again, there will be thickening of these bands as well as thickening of the axillary capsule. So where is the axillary capsule? So this is the axillary capsule. This is a U-shaped structure which we see just at the region of the axilla. So this axillary capsule is being formed, it is being reinforced by the joint capsule as well as the inferior glenohumeral ligament, the anterior and the posterior band, which forms a U-shaped structure. So based on these three planes with different sequences, I have not shown all the sequences because I wanted to show you the anatomy. So based on these three planes, we can see the all the structures around the shoulder. Like we can see the joint, we can see the labrum, we can see the bones, the rotator cuff, the ligaments, the bursal surfaces, the bulk of the muscles, the subcutaneous fat, as well as the neurovascular bundles. Now, where is the neurovascular bundle? So this is the supraglenoid notch. So just above, you are able to see some linear bright structures. These are the neurovascular bundle, which move. And as we see, this all going medially along. So, and also we have the inferior neurovascular bundle. So this is what the inferior neurovascular bundle is seen in the axillary nerve and the axillary vessels. This can be also seen nicely in the sagittal view, where we can see the neurovascular bundle in the supraglenoid notch. So this is the area where the suprascapular nerve also traverses. And sometimes we can see the impingement on the nerve, which can lead to abnormal signal in the muscles. So this is the neurovascular bundle, the superiorly, and this is the inferior neurovascular bundle. Right? So I think I have covered all the basic structures which we see, and in which plane which structure needs to be seen. That also I have talked, and I spoke about the joint, the ligaments. So this covers most of the structures which we do see in day-to-day practice, and this is not only for the radiologist but all the orthopedicians also. They also nowadays know how to see which sequence and at least which structures, so that they it will help them in the further management. So many times in the operation theater also, it will be needed that the films are there and they need to decide on some specific thing. They can see this and then they can move on. Right? So
Yeah, thank you, Amit. It was a really nice presentation, and anyone wants to ask questions before I ask my stupid questions? Anyone?
I think there are a few radiologists there. They know the anatomy of the shoulder very well.
Okay. Amit, it was a really nice MRI presentation, but most of the time we get a printout which is a very small one, and like very difficult to see all those ligaments, clavicular and other things. Is there any way like we get the CD and we can see on our computer, or we need a like?
So nowadays, most of the places they are either giving you the CD or they have started giving the links where you can directly see in the phone and the laptop or desktop.
No, many people would bring a link and then they say you can follow the link. So how to go about it? Because they just give us the link.
Yeah, so many times what happens that links doesn't work, and though the places where that they have a proper like
My question I was asking: can we open those link in a normal computer or a phone,
yeah,
or
the
do
links
we?
can be opened in the phone and the computers without any DICOM viewer. But
Okay,
if the CD is being shared with you, so most of the CDs they have the DICOM viewer installed in the CD. So you just have
okay,
to open it in the system and you can see. But many times what happens, this CDs doesn't work. That we are seeing in our daily practice
yeah.
also. Yeah.
So it's easier to get a link. Ask them to give us a link, and
Yeah, but the link will
get it.
only be available those centers or institutes where they have a facility for a link. So that
Okay.
again
Do we
involves
have the facility for the link in Max?
no, in Max we don't have. So none of the corporate hospitals they are giving this. I think Apollo has recently started, but that again involves logistics and some revenue.
Okay.
Yeah.
Okay. Any questions, Akram? Jyoti?
No, sir, no question. Sir.
Amit,
Okay.
it was very nice presentation. Thank you very much.
Thank you, sir. So either I have taught very well, or either I have taught very badly because no one is asking any
No, no,
question.
it was really nice. The way you done this MRI part was really, really nice because uh, it was maybe a special quality which you're seeing, especially the X-ray. I was about to comment on the X-ray. That axillary view X-ray, I could see the chromium through the humeral head. It
Yeah,
was a super quality X-ray.
yeah. So that was from one of my presentations. It was from Max only. So no, this
Okay.
MRI is a regular quality which we do. So that is just this MRI has been done I think day before yesterday.
Looking on a computer screen, because it's an enlarged view and you can see like in a sequence, like going from anterior to posterior. And but when you're seeing on a film, it is completely different experience. Like
Yeah, that is true. Sometimes what happens, the films are also given in different orientation. Sometimes they give from superior to inferior. They mix the images. They skip some images. So because the radiologist himself is not sitting and doing the many like
see, many
reference.
times patient just brings a one film. Like they get MRI done and they bring one film and whole shoulder, you're not sure what to do with that film.
So actually the thing is we don't have any
Those are,
standardized protocol in
those are
India.
the again logistic problems.
Yeah.
We can discuss that later. So if there are no questions, we call it a day. Akram,
Sir,
any
sir, I'm
questions?
here. Not really, sir. Thank you.
Okay, okay. Thank you, Amit. It was a
Thank you.
really nice effort you have put in, and I must say it was really nice. And we're looking forward to your next lecture of
Next
the
time, I
same
think
series.
we can divide it into pathologies. Like we can do just rotator cuff pathology once, then labral pathology, instability once. So it is better, like 20-25 minutes
Yeah,
thing.
we can have three talks like instability, curve, and miscellaneous.
Yeah.
Okay. Thank you. Thanks a lot.
Thank you. Thank you,
Brilliant,
everyone.
sir.
Thank you. Thank you.